I was stressed 100% of the time. And all I could think about was how much I wasn't getting done, rather than focusing on the things that I was achieving.
On today's program, we look at innovation in healthcare as one means of combating burnout.
For all of us who take care of patients in the course of our workday, we have been trained and conditioned by our educational process to continue to work despite the fact that our batteries are completely empty.
We didn't hear a lot about burnout before the pandemic, but it was there. And one of the culprits may just have been a tech advance itself.
Even before COVID, we saw the electronic health record as being a very large driver of burnout. With COVID and patients being able to access their health record and access their physicians at much higher rates, we are seeing even more burnout related to the electronic health record.
Coming up, a conversation about innovation in healthcare with someone at the cutting edge. Stay with us. It's the Hear Me Now podcast. I'm Seán Collins. Glad you're with us. Burnout was already a topic of conversation in medical circles well before we ever heard of COVID. And the pandemic only accelerated the departure of healthcare professionals from established careers. So maybe it seems counterintuitive to look to burnout as the germ of innovation, but that is exactly what seems to be happening. Providence has embarked on a multifaceted approach to addressing clinical burnout. And just as no one issue causes burnout, no one solution will cure it. Instead, they have a Swiss Army knife approach that includes innovation in a variety of areas, believing that by improving the experience of delivering care, they will improve the patient's experience of receiving it. Or as I've seen members of the team write, they're all about restoring joy in the practice of medicine. Dr. Maulin Shah is Chief Medical Information Officer for Providence and VP of Informatics and Engineering, and he's with me now from Portland. Dr. Shah, welcome to the podcast. It's really great to have you here.
Thanks for having me.
To restore joy in the practice of medicine, that's a tall order, but one that I imagine is really gratifying when you make strides towards achieving it.
Yeah, for sure. I'm a physician myself, and seeing, my peers, my colleagues burning out, getting tired. I was just talking to my sister literally yesterday at lunch about how she's a hospitalist here for Providence, and how she was feeling like she just wasn't sure how much longer she could do it. It's a real problem, and COVID or not, like you mentioned. And so, my job here at Providence, and I think all of our jobs, is to do everything we can to take the burden away from administering care, and being there on the front line so that you can focus in on your patient and the stuff that brings you joy, right? Like the stuff that as a frontline caregiver brings you joy and allows you to do the most good.
Yeah. And it makes financial sense too, right? How much does it cost to recruit and hire and onboard a new physician?
I better not quote the number because I'll probably get it wrong, but it's definitely six figures. It's a lot of money. And by the time they're onboarded and seeing a full panel of patients and understand all the Providence nuances of how we care for patients and what we do, it can take quite some time as well.
So anything you can do to retain and improve the work environment for existing caregivers, as long as it's below that six figures, you're ahead, aren't you?
Absolutely. And just think about the patient experience, right? I mean, you don't want your doctor to leave and have to see a new doctor, then have to see a new doctor. I mean, it's important for the commitment we have to our patients.
As I nosed around this topic in preparation for the episode, you get the sense that people begin to equate burnout with the sort of simultaneous adoption of electronic health records that happened historically. I know that that's too simplistic of an association, but I think a lot of people are making it, and that idea is out there in your work environment. How do you approach that issue?
It is a good point. I mean, if you think about how health records got wedged into healthcare, it was through a government initiative, right? It was through initiatives that forced the utilization of a tool, no matter how mature or immature, because frankly, healthcare was kicking and screaming when it came to health information. It's funny, we're cutting edge when it comes to like robotic surgeries. All the docs want to do it, but when it comes to health information management, it was something that they were really kicking and screaming. And so, if you think about the initial incentives being, how often are you clicking here or doing this one thing or doing this other thing? The tools got built for physicians and for care, first out of the need for better billing, and then out of a need to address these meaningful use, which is what they would call the meaningful use criteria. So no question that these were not clunky tools that were not sort of designed with the clinical encounter in mind. They just jammed stuff in there. I think over time that's actually gotten better, but you only get one chance to make a first impression. And so It's taking a very, very long time to, really show people how things have improved. And one of the things my team really focuses it on is saying things have improved, but you've chosen not to do them. We have these modern web browsers, or we have modern things, and you guys are still, using Internet Explorer from 2002. So how do I get you to move forward along with these tools and get you out of kind of your practice patterns?
So walk us through some of the innovation that you're bringing to that sort of training, mentoring that goes on in sort of helping physicians and nurses to adopt a tool that they think they may not like.
Yeah, we have a number of different kind of approaches. Now, like you said earlier, no one approach is going to work for sure. At the highest levels, we got to make sure our tools are as fast as they can be, just from a performance perspective, that they have a nearly 100% uptime. So there's infrastructure, right? There's security. There's these things that you don't want to ever have to think about. Wireless network infrastructure, all that stuff that nobody really wants to think about. Things should just work. So that's the first thing about building trust, and that's what we work on as an IS organization. But then you dive into kind of okay, I trust that this thing will not be broken. That's good. But now what do I do? We can kind of split our approach into a few different areas. On the front is training. It's not what people get very stuck on, training being the thing that happens when you join the company. Well, that may have been 10 years ago. For me, it was 17 years ago, right? Mm-hmm. Like that doesn't help me anymore. And so changing the paradigm of training to an ongoing process, to be able to be something that you're constantly learning, however we can deliver that training to you in a busy clinician's life, is sort of the first piece. That includes us looking at the data provided by our electronic health record vendor that says this particular clinician, this particular physician is super efficient, or this person is not efficient. And so we can target those physicians or nurses that are not as efficient and say, okay, well, these are people that we need to spend a little time with. But also just ubiquitous training for everybody. And then for those high performers, giving them even more training, power user, if you will, is what Epic calls it, our EHR vendor calls it, so that they can then they can pass that along through like osmosis with their peers, right? Like they know, people know, oh, I can talk to such and such and I'll get better at this, or I have, so there's that. That's training, and part of that's what we call coaching, where you can reach out and have a one-on-one session scheduled with an expert to say, how can I make my workflow better? So lots of different opportunities.
You seem to be pointing to a really ancient tradition in medicine, which is that people are mentored by their elders and they learn by watching, and they get good at something because of that training. And then they teach others how to do what has been passed on to them.
Absolutely. See one, do one, teach one is what we all learned in residency. And to the extent that we can do that and leverage that culture, the better off we are, right?
Might need to be C50, do 1,000.
It should have been C50 all along. Let's just be clear. I shouldn't see one appendix and do one. That was never a good idea. I'll close out on training, but like the last thing about training is that it is the best bang for our buck. So if we spend $1 on training, we will get the highest return compared to spending $1 on making the tool easier to use, or $1 on some, new innovation. So it's simple, but it's clearly the best work. It's just, when you go and talk to a doctor, like, well, why can't you just make it easier? Well, we spend a lot of time making it easier. You're not using it, and that's why we have to train and train and train. So that's number one.
So as a person who has watched his primary care doc during encounters, I've noticed part of her work seems to be pulling down multiple nested menus and clicking, click, 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 click. It seems like there's so many steps sometimes to get to what she's trying to put into the record. And that just seems like kind of awful Web.1 user interface design. I mean, as a complete newbie, I can't believe that it's not easier. And
so now you've said the speech that every physician I've ever met tells me. So you just got your MD. No, you're absolutely right. I mean, the user interfaces have not come along. Some places where they have come along, and again, our vendor is working very hard on that. They're not in the traditional work. You kind of have to change how you do your work to get to that, and it generates a note differently. But what I really feel like, and this is where the innovation stuff comes in, is we have to step away from the paradigm, right? You can only improve something for so long. Great, make the computer better, make the computer better, make the computer better. You can only do that for so long. So what one of the things that we've done is we've partnered with a company called Nuance, who is a Microsoft company. They've put together some pretty amazing innovation called the Dragon Ambient Experience, or DAX. So to get to your example of you're sitting in the exam room, your physician's clicking, looking at their computer. Maybe they look up and look at you once, and then they can start looking at it. It's like, who are they taking care of? You or the computer? Dragon Ambient Experience, DAX, attempts to address this directly. So it listens to the conversation so that you and your physician can be having a conversation directly. It listens to that. And then from that, it generates a clinical note. So the physician's not busy looking for drop-downs, but instead can just have the note already there. Then when the physician's interacting with computers for very specific things like decision support, or how can I best take care of this patient, or what are your medications doing, and that kind of stuff. So you still have the computer, but you're doing the right work with it. You're not just sitting there transcribing that somebody else can do. I'll just add that the current version of DAX that we're one of the larger users of with our physicians creates a note, but it takes 4 or 6 hours to get the note back. So you get the note at the end of the day, you review these notes, and then you sign them, and off you go. With that in and of itself, overall, there's been a lot of satisfaction, and things have really gotten better with that. But it wasn't enough. And so Nuance has recently announced a product called DAX Express. So this is a GPT, so ChatGPT. It's enabled by ChatGPT, not the public ChatGPT, but a private version that's hosted in Microsoft. But basically, it uses GPT to create that note in real time. So now I have a conversation with you. Then when I look to the computer, I've got a note. So all that work I'm doing with the note, it's all right there.
It doesn't generate a transcript. It generates something that is a synthesized version of what was said.
Yes, absolutely. Yeah, both versions. Yeah, they are a synthesized version of it. So they'll say, patient comes in with X and has been feeling such and such, and it's a really impressive tool.
Have you used it with a patient?
I have not used it with a patient. Actually, it's not available for general availability yet. They're kind of on a private preview. But we're definitely excited to pilot it as soon as they get out of that preview.
And can I ask whether you've used it in any sort of beta form with a colleague, sort of not with a patient, but with someone else?
No, not yet. Not that instantly available one. We haven't got our hands on it yet.
I'm really curious what that experience is going to be like for the clinician, right?
Absolutely, we are as well. And again, so I have the chief medical information officer. We have a couple in our organization. We have an ambulatory focused chief medical information officer, Dr. Scott Smitherman. He's been using this in his clinic, the DAX version, and he's like, for the first time, I can just go home on time. that again, you were talking about burden and burnout, right?
Right.
I get to go home on time. I don't have to open my chart again after going home. That's just a huge win. And that's without the newer version that's going to be real time, which we're super excited about.
It's like someone hands the doctor, here are 4 hours of your life back.
Absolutely. What's really interesting is, you get an hour, maybe 90 minutes out of the DAX. You get another hour from training, which is what we've quantified. So, I mean, you're talking about a couple hours a day of people's lives coming back to them. I mean, that's not subtle.
Wow. Do you know how many episodes of Survivor you can binge if you use it?
Right.
So we should be keeping an eye out for this DAX, which again stands for Dragon Ambient Experience, right?
Yeah.
When do you think it'll be ready to beta test in a clinical setting at Providence?
At Providence, probably end of the year, maybe early next year would be my guess. And we got to be careful, right? I mean, especially the generative AI, right? It's exciting, but it's also not only new, but there are some very real risks with the generative AI. You've probably, many of you probably heard about hallucinations where it'll just make stuff up. So it's listening to your conversation, and theoretically, it could just make stuff up. Now, the Nuance company is clearly like checking it and making sure it doesn't do that, but that's what we're waiting for, right? We want to make sure it doesn't do that. But there's a lot of other things that are really hard to test. Things like bias. Could it create a different kind of note based on the kind of the way people talk, right? Because this is a model that was just trained on the internet, conversations on Facebook and Reddit, right? So is it possible that we'll be creating bias in our care because somebody speaks with a particular vernacular? I don't know. I hope not. But hope not doesn't feel good enough for patient care. And so we're waiting a little bit. We want to see what's going to happen.
So you're going into it with your eyes open.
Absolutely.
Yeah. At the sort of practical level, is there a way, not with the generative version, but is there a way to sort of trigger it to make a verbatim note, almost like a Siri encounter?
Yeah, and that's stuff that we're looking into. There's a tool called Hey Epic. Epic, again, is the name of our EMR. So you say, Hey Epic, and you can have it do things. There's some talk about the Dragon experience having a similar thing where you can turn it on with as an assistant, a virtual assistant. None of that's super far along. Hey Epic is live in our system, and its utilization's pretty low, just to be honest. I mean, I think, frankly, I use my Alexa a lot more than before when I first got it than I do now. Now it's like a glorified shopping list and an iPod, right?
Yeah.
So it's that kind of a thing. We just got to find the right use case.
Dr. Shah, I think whenever there's talk of innovation, and particularly when there's artificial intelligence mentioned in the conversation, I think some people are going to put up mental roadblocks. They're going to think they're turning us into bot fodder, really long numbers. And I'm curious, what does Providence do to ensure that the humanity of the people that are being cared for doesn't get forgotten in the environment of innovation?
Yeah, it's a great observation. I think the biggest thing to think about is the AI is not necessarily about helping patients, to be honest. It's about helping your caregiver, your clinician, your physician, so that they can still help the patient. It's about allowing physicians to be human again, creating that human-to-human contact, which right now, like we said earlier, they're busy looking at a computer and they're not looking at you, right? So if anything, my hope and vision for AI is to get rid of all the administrative stuff, even serve up the clinical stuff in a way so that I, as the human, as the physician, can sit and talk to you and have the information I need at the tip of my tongue so that we can make a decision together. So it's far more about that than it is about we're not replacing physicians. Even if the technology was there, I don't think the humanity is there, right? And the technology is not there. So it's not about replacing really any kind of staff, but about augmenting our ability to do a better job.
Can we talk about whether this move that you're undertaking at Providence is going to have any impact on the care for diverse populations who might be slipping through the cracks in other ways. Is there any hope here that this could make care better for more people?
Yeah, in a number of different ways. I mean, and maybe they're a step or two further, right? But if I can more systematically and more consistently interact with my patients, right? So I know I'm going to have a certain set of information about my patients. I don't have to go searching in a chart for it because, for example, AI has served it up for me, right? I know that my team has had standardized workflows enabled by AI to be able to prepare your patient for a visit, whether it's, make sure you bring in your medications or make sure you find the records for something or whatever it might be, or so that I have kind of a consistent approach to every patient. Then by being standardized and consistent, I know that I'm going to be able to, one, just make sure I'm reducing any implicit bias and making sure that we're being inclusive and really respecting the diversity of our patient population. Secondarily, though, the mission at Providence is around care of the poor and the vulnerable. And as you think about how AI or other innovations can impact that care, things that come to mind right off the bat are just access to care, right?
Yeah.
Like, so making access more ready, more available, being super smart about how we schedule patients, being super smart about who's going to not show up. We have a machine learning AI model that helps us to predict whether a slot is going to be filled or not, or if somebody's not going to show up for whatever reason. And if not, we call them to try to get them to show. Like, we don't want them to no show. We want to say, these are the targeted people that we can call and try to have them come. Can I send you an Uber? Whatever it might be. We need you to come to this appointment. But then if you're not, I've opened up access. So you've done a couple different ways by predicting who might not show using AI to help improve access to the clinic or access to our care. It's just, there's a lot of different examples of how you really optimize the time of the clinician.
And access to the information about your care. Like, now that the health record is available for patients to read, does everyone have access through a phone or through a computer to be able to access that on their own? Or if they're elderly and are, not interested in learning a new technology, there's that diversity angle to it.
Exactly. And I think that's what we have to be careful about, right? Like, so as much as we have adoption of our electronic tools, our mobile tools, the things that are on your phone about your care, that's not everyone. And in fact, the people who are most likely to slip through the cracks are the ones who are not engaged, right? So it's very easy for me to do an outreach program to those that are connected. I can say, you're due for your colonoscopy, whatever it might be. But and so I'm glad I can make the care better for those that are already receiving good care, but that's missing those that don't. The access problems, for example, like the one I just mentioned, where I'm calling you because I think maybe you won't show, and I have no idea how the algorithm works. That's the beauty of it, right? But the algorithm works, and maybe it's checking, do you have an account with us or not? It's unclear, but the point is that it's we're trying to find a way to be a safety net to catch those people. Yeah. Even when they're not, electronically engaged with us. I want them electronically engaged, but not everyone can be.
Right. I hate to keep hearkening back to this model of comparing everything to old things, but I sometimes think it's useful for people who are reluctant to embrace new technologies to remember that this is sort of the way it used to be. If there was a patient on your schedule for the day and your receptionist noticed that, they don't have a car, or their car broke down, then they were late the last time, maybe I should call and find out, do you need help getting here today? I mean, in the most humane, human way of interacting with patients, it's what used to happen.
Yeah. We're trying to do that at scale and cost, right? Yeah. So if I had enough people, right, the proportion of people that a practice sees and the proportion of office staff, you could have those same exact relationships, but you'd only have them in that clinic. We're trying to do it across 1,000 clinics, and we want everyone to get the same experience. And the way to do that is to to use technology to help us, to help our humans be human again.
When you look ahead, I don't know, 20 years, what do you think medicine's going to look like that's radically different from what it looks like now?
Well, I'd say the biggest change is you're going to have less care. I don't think you need as much care as we're doing if we do it right. In other words, we'll be focused on preventative care, lifestyle medicine, really making sure without you even necessarily being aware that we have shifted the habits and that we've kind of helped you to have the best habits to take the best care of yourself. That's not to say disease goes away, but I think you'll see a focus on health. That'll be first and foremost in my mind. And by focusing on health, ideally it's as transparent as possible for you, right? Like, so you're just healthy. I don't know how that works. That's why it's 25 years from now. But it feels like there would be ways, whether it's using wearable technology or technology, that tells us kind of how you're functioning and, hey, you haven't walked in a while, or, it seems like you might be limping on your left foot, whatever. I mean, I don't know the level of detail we need to know, but then you put that into some serious analytics and computational power and create a picture of lives that have committed and said, you know what, I want you to help me stay healthy. And we find a way to help you stay healthy.
Yeah.
Again, no idea what that actually looks like. I think, disease care is still going to be in some ways, something that's transactional. I mean, something that you have to come in and someone has to see you. But even disease care, I think you'll see us be able to do less and less of it, not just because you're staying healthy, but because we know the exact interventions that are going to work exactly right for you, whether that's because we genomic-based care where we know this medicine is going to work. You don't have that, oh, I don't tolerate that medicine. We're like, yeah, we knew that up front, so we didn't even try it, right? So I think you're going to find more and more targeted care so that even the disease care is going to be more transparent, so that we're just doing less of it. People ask and they want to, what I hear, I've heard this question before, and you hear things like, well, you won't see this at the clinic or in the hospital, you'll see this thing, or you won't see this thing. Again, my hope is all those things are just getting smaller and smaller and smaller. And that they're just becoming less a part of our lives.
Yeah.
You have to have them.
I could imagine a universal shift in the point of care, that it moves to your home. It's like that's the primary place where healthcare gets delivered.
Yeah, or it moves to your phone. I mean, it moves to wherever you are, or whatever your device is in 25 years, right? It's completely mobile. It's completely with you when you need it. And we've seen that already, a transition there happening, right? But whether it's, telehealth that we've been, investing in and it's skyrocketing, whether it's additional use of wearables, whether it's use of wearables that are now monitored by your clinical team, by your primary care, or
right.
But I really just think it's the beginning. I think it's the beginning. Because so here's the thing. Fitbit came out whenever, 10, 15 years ago, and it was like one of the first wearables, right?
Right.
And it tracked your steps and stuff like that. And one of the things was like, oh, we have to get this to your physician. And physicians are like, I don't care. It's too much information. It's just, nice. I'm glad you're walking, but it's too much information. And the more and more monitors we have to monitor your health, who knows what we'll be monitoring, the less any one person can look at it. Yeah. But if you take all that data and you put it through a machine,
yeah,
and you can come out with insights, now it's like, oh, you know what? Based on all this stuff, this person could probably use a phone call.
Right. So it's insight at the other side of this sort of data fog of all this data that's going to be available on you.
Right.
Rather than asking anyone to try to make sense of it, the machine does that and produces like, you should be paying attention to these three things, or
right.
Yeah.
And I don't think that's not us not caring for them. It's us targeting our care.
Yeah.
To the right thing, because nobody wants their doctor to be part of their life. Ideally, you wouldn't be sick. So it's sort of changing that paradigm.
Right. I'll just add this as a testament to what you've just described. A couple of weeks ago, we had a guest who talked about food as medicine and talked about the importance of changing diet and the impact that has on heart disease and hypertension and all sorts of disease processes. So when you say, I can imagine that that people are healthier and they're getting their care at home, if people changed perhaps the way they ate and moved, That could happen in 25 years. It could be a generational change. But as someone who's obese and who has heart disease and diabetes and it's fallen apart in all sorts of ways, I've let my watch start to give me more information. And like initially, I was afraid to turn on the activity stuff because it's like I didn't want a nagging reminder that I'm not doing what I should do. But it has really helped me. I've lost 55 pounds in 7 months.
Wow.
And
Amazing.
when I was in with my primary the other day, she said, "What's different? What have you done differently?" It's like she saw the data and said, "Tell me what you're doing." And I quoted the guest from the podcast and said, "I've been chopping more vegetables." And she said, "That's great, and I've been moving more." But that's all mediated because there's something on my wrist that's reminding me that, oh, it's been an hour since you got up from your desk and moved around. And I think that's important in some really important way for me. I think it's going to change the way I live.
Yeah.
And I can see that happening universally.
I'm going to go back to the Swiss Army knife, right?
Yeah.
So for you, that knife was perfect. And somebody else is going to need a corkscrew, and somebody else is going to need a bottle opener, and all the things in that Swiss Army knife. And it's on us to help be creative and imaginative about how we're going to support people. Because I think that's, again, this is what happens, right? Your story is amazing, and congratulations. So I hope people hear that and think about the watch as a biofeedback mechanism and about chopping vegetables, and can have that experience. But we know others are going to have different motivators, are going to be able to they are going to think it's a nag, and it's going to actually be harder when they do that. So again, the data can help us with this, even though I know that sounds kind of inhuman, but like the data can help us and be like, you know what, this person is most likely to be motivated by a biofeedback mechanism. This person is maybe more motivated by a daily summary of what they did so that they can change tomorrow, or I don't know. So I hope we continue to build more and more innovative ways, but we don't get stuck, because when we get stuck, back to your point, people fall through the cracks.
Yeah.
Right? We got to have ways to help everybody.
Dr. Shah, thanks so much for the work you're doing, but also for taking the time to talk with us today. I'm really grateful.
Oh, you're very welcome. Thanks for having me. Maybe we'll do it again on a focused topic. I'll send you some cool stuff.
Always interested. Speaking with us there from Portland, Oregon, Dr. Maulin Shah. He's the Chief Medical Information Officer for Providence and the Vice President of Informatics and Engineering. The Hear Me Now podcast is a production of the Providence Health System and its family of organizations. Find us online at hearmenowpodcast.org. The program is produced by Scott Acord and Melody Fawcett. We have research help from medical library staff Carrie Grinstead, Basha Dolofska-Elliott, Sarah Viscuso, and Heather Martin. Our theme music was written by Roger Neal. The executive producer is Michael Drummond. I'm Seán Collins. Thanks for listening today. Be well.